let's shift gears and look at some of the study designs we have in improvement and research. And I see them as a spectrum now. On one side, we have pure clinical research, which is heavily controlled on the green side. And on the far right side, you see the improvement science, which deals with system redesign and reliable implementation. In the clinical research domain, we are seeing a shift towards cluster randomized trials and pragmatic trials, which are now taking the context into perspective as well. Such study designs give us findings that are closer to the real life scenarios. On the improvement side, we also have experimental designs like the natural experiments, factorial designs, and fractional factorial designs. Using such designs, we can have a more robust relationship of each individual factor with the degree of improvement and if they have a synergistic effect or not. Let's go over these clinical study designs. We all are most familiar with randomized controlled trials. We take a sample size from a population with an intended inclusion and exclusion criteria. Having a fair randomization is key to reducing the bias over here. So everyone has equal chance of being randomized to either of the groups, which could be the intervention group or the control group. They receive the intervention and then the follow-up, we measure the outcomes of interest. There is loss to follow-up in between and there could be loss of adherence, but in general, this is a strictly controlled environment where other factors are taken into account and controlled to the maximum effect. Then we have cluster randomized clinical trials. Over here, the randomization happens at the level of a community or a clinic or a physician or a hospital rather than at the level of an individual patient. If we have multiple clinics and hospitals, we would randomize one hospital to one arm, another to the other arm, and so on. So there's a randomization of the settings rather than the randomization of each individual. So there is an opportunity to look at the contextual factors of these individual sites as well when we are doing our analysis and interpretations. Let's look at this example of a cluster randomized clinical trial for controlling blood pressure in black barbershops. They randomized black barbershops into intervention arm or just education and control arm. So in one arm, the barbers were giving them general information. In another arm, there was a pharmacy-led initiative to help people assess and manage their blood pressure. In the end, they found improvement in the pharmacy-led interventions. Then we move on to adaptive clinical trials. This is a very interesting design, and I think it's closest to our improvement mindset as well, that you come up with a protocol and hypothesis, and then you test it out in a pilot phase. Learn quickly that what is working and what is not, and which of the groups need to be stopped or continued. So there is a flexibility in the hypothesis at the beginning of the trial. And once they learn, they adapt and then modify the protocol to the next level before spending too much time and money on one fixed hypothesis. So think of this as something very close to our PDSA cycles in our improvement science, but of course with the robustness and sample size of clinical research. And then come my favorite ones, the pragmatic trial design. So pragmatism in clinical trials arose from concern that many trials did not adequately inform practice because they were optimized to determine efficacy and were not representative of real-life scenarios. So how pragmatic is the design? It depends on these 9 dimensions. The first one is eligibility. Is it narrow and strict? Versus is it broad and more representative of how we do clinical practice? The recruitment is not only limited to highly academic and restrictive settings, rather it's general and includes communities and clinics. And the organization of the trial is within the clinical infrastructure of usual care. The delivery of the protocol is a bit flexible, so people can opt out or have adherence based on how naturally people behave. There is no role of incentivizing the participants or censoring the participants and hiding the poor adherence. The outcomes are patient-centered, and the trials use intention to treat analysis, which means that once you're assigned to a group, you'll be analyzed as part of that group, even if you had low adherence or you switch to the other arm of intervention. Let's look at a recent example of comparative effectiveness of aspirin dosing in cardiovascular diseases. So this is an open-label pragmatic design study in which they had 15,000 participants, and they were assigned to the group of 81 milligram aspirin or 325 milligram aspirin to measure its effectiveness in secondary prevention of cardiovascular incidents. They used EHR based algorithms for screening. The consents were done virtually. They patient centered materials for education and used visits for follow ups. And the pills were bought by the patients from over the counter. That is truly real life. Now, you have to understand there are limitations of these studies as well. For example, in this particular study, almost 40% of the people who were assigned to the 325 milligram aspirin group switched to 81 by their own choice by the first follow-up. The study did not show any difference between these two dosages, but how much of that is influenced by people switching from the assigned group to the other group. So there are limitations, and it did not give us the answer for the dose effect, but it did give us a real-life picture of what would people do, and the study was completed with far less budget. Let's move on to my favorite part of the talk, which is capitalizing on the experimental designs in QI. So here we have time series, natural experiment, factorial design, fractional factorial design, N of 1 trial, and more. And within the time series, we also have before and after, time series with replication, time series with the control group, or planned grouping. So I'll give you some examples to walk you through them. So the project work that most of you have been doing is a simple time series incremental improvement, that you have a baseline data and then you do some incremental improvement interventions, and you're hoping that your interventions would lead to a special cause change, improved outcome. Now within this time series, you also have the ability to try out different things to improve your degree of belief that which factors are actually making the difference. You could pause your intervention and see if the data shifts back to baseline, and then reintroduce your intervention. So you could kind of pause and restart. You could also have a control group. For example, on one floor of the hospital, you are doing an intervention, and other one could be used as a control group, and so on and so forth. So within time series method, you could also add more degree of belief by using a different experimental design. Let's take an example of planned grouping. This slide shows the work we did in UC Health ICUs for reducing CLABSIs and COTIs, which are catheter-associated bloodstream infections and catheter-associated urinary tract infections. We had 8 ICUs participating in this initiative, and we identified some of the key process measures that need to be reliably implemented. But of course, we are starting new, and we did not know how best to implement these process measures and what will be the final form in which they will be implemented. So instead of all ICUs working on all measures, every ICU was given 1 to 2 process measures to work on and refine and quickly develop best practices. And then those practices were shared across ICUs, and we were able to help the whole system achieve much reliable performance in a faster time frame as compared to if they had to go through learning each and every process measure by their own pace. So this is an example of planned grouping in which we can accelerate learning and then share it with other places. Okay, now let's move on to learning from natural experiment. You're already familiar with the COPD readmission reduction project, in which we implemented a 5-component COPD care bundle before the patients are discharged. Now, as we were doing the project in the early phases, there were times when some patients received some components of the bundle and not all. This gives an opportunity to do a natural experiment, where you have some factors that are delivered to some patients and some factors are not. And you could use the same thing in one of your own experiments. So in this grid, you can see that we have assigned the groups based on 4 factors: whether they got the standardized discharge instructions or not, if they got the medical supply in hand before they left the hospital or not, did they get the inhaler education or not, and if they got 15-day follow-up appointment or not. And then we have the number of people who were readmitted and the total population in that category. So what we could see over here, people who had the least number of readmission rate were the ones who received all of those bundle components. One of the comments I received was, if you are giving them inhalers in hand, That alone might be good enough for reducing readmissions. But you can clearly see over here that people who actually got inhalers in hand, the med supply in hand, but did not get inhaler education or standardized discharge instructions still had a high readmission rate. The limitation in natural experiment is that all subgroup sizes were not designed to be equal sizes. So we have buckets that have lots of people in it and buckets that have very few people, like 0 or 1. So we cannot really learn from the interplay of all factors. This, however, can be done by an intentional factorial design. So here is the study design for improving diabetes care. Their outcome measures were hemoglobin A1C levels and the ER visits of these patients. And the 4 factors they're trying to study over here are care management or no care management, using intermittent dose of insulin versus insulin pump, targeting easy glucose targets or tight glucose targets, and then having sick day guidelines and no sick day guidelines. They want to have 20 patients in each of those buckets to test out how each of those factors interplay with each other, which of them are synergistic, and which of them is not needed or actually is hurtful. Such a study requires lots of work, thought, and effort, and of course, this would only be needed when you have uncertainty if any of these factors are not needed. If all factors are established best practices and have effective clinical outcomes, then it is not worth testing it through a factorial design. Then just try to embed that in your practice. But if their evidence is weak and you're not sure in your context if those factors are going to work, then performing a study like this can really help you tease out where you want to put in your effort and what you want to implement and which ones that you can let go of. So you're starting the study from a place of uncertainty, and by the end of this, you exactly know what elements and what factors are you going to embed in your system and implement for best outcomes. Now let me show you an example of fractional factorial design. So fractional factorial design is same as factorial design, but instead of populating every bucket, you actually reduce the number of buckets you need to populate while you are maximizing your learning. So your resource is less, but your learning is still robust. The example I'm going to share is a survey that I performed at one of the LAM conferences. LAM is a rare lung disease, and there are certain LAM clinics and centers throughout the world. In this conference, people from all over the world were meeting together at an ATS conference, and those were the directors of LAM clinics. There were 35 survey responders, and I performed a conjoint analysis to figure out what is high priority among these 4 factors. Would the clinic leaders would like to follow patient-reported outcomes? Would they like to follow outcome metrics reported for LAM? Would they like to look at standardization of diagnosis and treatment? Or would they like to have research portals available at their clinic? So in a conjoint analysis, these factors are presented in a way that they are mixed together and they are mixed and matched. So you could see over here that instead of having 16 buckets, we now have 8 buckets. Some buckets were not filled, but the algorithm gives us a design in which we can maximize our learning while creating less buckets. So by just looking at these 4 factors, one would imagine that all 4 seem to be important, and maybe all 4 are needed. But let's take a look at the results. Here are the 8 different scenarios which gives different combinations of the 4 factors that we talked about. And the highest score goes to number 3. This is where people are favoring tracking outcome metrics and having standardization as the highest influencer, whereas having all 4 components actually has a lower median score and a greater spread among responders. So this way we can tease out which factors are most important, and furthermore we can see that some factors are actually synergistic or they cancel each other's effect. So these are some of experimental designs we could use in leveraging and improving our learning from our improvement journey. Such designs can help accelerate our learning and also improve our degree of belief and give us a better understanding of interplay of different factors and interventions. So let's take a pause here and see if you have any ideas how you could use some of these or if you have any questions. Now let's spend a little time talking about IRB and QI. Should you do it? Should you not? Maybe? Well, I think the default answer should be yes, especially when it deals with patient outcomes that you're trying to improve. In most scenarios, all QI work will fall under non-human subject research. It will get an expedited review from the IRB and it will then be exempted. The fundamental goal of this project is to improve the local system for better outcomes. And in that aspect, it does not fall under the criteria of research of creating generalizable knowledge. Of course, these are human subjects, but this is not research. Now, if you are doing a project that is halfway done or just about to start a project, I would recommend that fill out the form in the IRB portal. And here is the link for the portal. All you will have to do is fill out some categories and some boxes on this web page, and then fill out the form for non-human subject research determination. What you essentially want to say over here is that this is a QI project designed and intended to improve the outcomes of our own clinical settings and our environment. You should mention that what PHI and other information you'll be accessing and what kind of reports you'll be generating. Here's an example of how I filled out this page for a project that was initiated by some of our fellows at Drake LTAC to reduce accidental decannulation. And then also fill out the form that is supposed to be filled and attached. Now lastly, let's talk about publishing in QI. The guidelines available for writing down the manuscript are known as Squire 2 guidelines. They are very nicely written. They help you guide not only your manuscript, but also your improvement journey. So you can start looking at this even when you are just at the initial phases of your project. Guide you about the title, the abstract, the introduction, that what is the problem description, what was the available knowledge, the rationale, and your specific aims, and then how did you execute this? What were the methods used? What were the interventions used and the measures that you tracked over time? You have to mention the ethical consideration and if your IRB exempted this or not. And then you report your findings, and most commonly done through control charts, run charts, and time series analysis. I highly encourage you to take a look at this and go through these sections. You will see that all the skills you have learned in this course will enable you to put together a nice story, a nice manuscript, and fill out all of these boxes. Then there are multiple avenues where you should aspire to present your work. And I think it's very important to present all the effort and the work that you have done, because I'm sure someone else is struggling with a similar problem and could benefit from your learning and your sharing. With that, I would like to see if you have any further questions or points to discuss. Thank you for listening.